Olá, eu sou o Dr. FABIO SCHUTZ, oncologista clínico da BP, Beneficência Portuguesa de São Paulo, também membro do LACOG-GU. Eu estou aqui hoje num evento da Springer Healthcare, que é um evento chancelado pela ASCO Direct, que teve o objetivo de fazer um sumário dos principais apresentações e abstracts apresentados na ASCO-GU, que foi em fevereiro desse ano em São Francisco, e também na ASCO Annual Meeting, que aconteceu esse mês recentemente em Chicago, em 2019. Eu estou aqui também com o meu colega Fernando Sabino, oncologista clínico de Brasília, o Dr. MARCELO WROCLAWSKI, urologista daqui de São Paulo, do Hospital Albert Einstein, e nós também o prazer de ter aqui ao meu lado o Dr. EMMANUEL ANTONARAKIS. Ele é professor doutor da Universidade de Johns Hopkins, de Oncologia Clínica, e nós vamos hoje conversar sobre os principais achados e discussões que nós tivemos hoje no período da tarde. Bem-vindos. Dr. Antonarakis, so I'd like you to comment a little bit about we have the presentations about the new stuff or new presentations or new abstracts that were presented in ASCO about the metastatic castration-sensitive prostate cancer. So can you comment something about how are you going to select the treatment between the docetaxel and the new hormonal agents, and among those new hormonal agents, do you have any criteria you can select the treatment for the patients?
So first of all, I would like to say this has been a lot of fun here to learn from the Brazilian oncologists and urologists about how you are managing your patients, which is sometimes different from what we do in the US. And it's a paradox because we have a problem now with medical oncology that we never had before. And the problem is we have so many drugs for the early metastatic hormone-sensitive disease. 3 years ago, we were treating all of those patients with ADT alone, androgen deprivation therapy, which was a bad sign for our patients, but it made our lives quite easy. We had just one drug, and we all knew how to use it. We were comfortable with the side effects, the indications. And now, within 3 years, we have at least 4 options that we can add ADT with something else. So we, of course, have now docetaxel we can add. We have abiraterone that we can add. We have enzalutamide, and also now apalutamide. So 3 years ago, one single standard of care. Now we have at least 4 standards of care, which on the one hand is exciting, and on the other hand poses a lot of problems because we don't have the studies that will guide us. How do we choose one over another? One thing that I find useful to help with the decision about docetaxel early versus AR therapy early is the volume of the disease. So if there's a high volume disease, docetaxel would be my usual preferred choice if the patient is chemo fit. And the high volume disease is, as you know, classified as more than 4 metastases in the bone, one of which has to be outside the axial skeleton, or the presence of a visceral metastasis. So if patients have high volume disease, they will clearly benefit from docetaxel, but they will also benefit from abiraterone, enzalutamide, and apalutamide. In the low volume patients, I typically do not use docetaxel. It's less clear in those patients that docetaxel adds a survival advantage if it's used early. Of course, it can always be saved for later when the patient develops castration-resistant disease. And in those patients, I think apalutamide, enzalutamide, or abiraterone are options. Right now, apalutamide is not yet available for those patients. Enzalutamide is available, but not specifically FDA approved. And abiraterone is available and FDA approved. Between the 3 hormone agents, I like to use abiraterone because I'm more comfortable with it. The data is more mature. We have longer follow-up for those patients. And with few exceptions, for example, in patients with diabetes with poorly controlled hemoglobin A1C or glucose levels, I may not want to use abiraterone plus prednisone. But for most of the other patients, if I decide to use a hormone therapy plus ADT, I will choose abiraterone.
Okay, excellent. Marcelo, can you comment something about the treatment of the primary for those patients with low volume with metastatic castration-sensitive prostate cancer? That was the arm G from the STAMPEDE trial.
Sure.
Any surgery, radiotherapy, as a urologist, can you comment?
So these prospective randomized trials, they were all published with radiotherapy in this setting, which is the STAMPEDE and also the HORAD trial, and they showed benefit, overall survival benefit for patients with low volume disease. In the STAMPEDE, that's for the shortened criteria for low volume disease, and in the HORAD trial, patients with less than 5 bone mets. Nowadays, there are some trials going on. There's the SWOG trial conducted by Brad Chapin from MD Anderson, and there's a trombone trial conducted by Dr. P.S. from UK, where they are studying the role of radical prostatectomy in this setting. So there are some retrospective data showing that radical prostatectomy may be as effective as, or even better than radiotherapy, but for now, I guess for low volume disease in the hormone sensitive metastatic prostate cancer, radiotherapy is the standard of care.
And Emmanuel, in the United States, have you also been sending those patients to radiotherapy with low volume?
Well, I would like to say that the radiotherapy arm of the STAMPEDE study has some controversy as well. We have to remember that the entire study was a negative study.
Yeah.
Right.
And it was published in the Lancet, and if you read the conclusion of the abstract, it says the primary endpoint was not met. However, as we all know, in the subset analysis, which was pre-specified and was powered for an independent analysis of the high volume and low volume patients, we did not see any advantage in the high volume patients, but we did see a survival advantage in the low volume patients. So it really depends on your perspective. If you are one of those believers that you should only do a subset analysis if the primary endpoint is positive, then you would not generally recommend radiotherapy to the primary. If you're one of those people that believes that because the subsets were pre-specified with a statistical plan that was determined ahead of the analysis, that's very important, and it was positive in the low volume group, then you have a license to give radiotherapy, let's say, to the primary if you wish. So I don't think it has become the new standard of care to radiate the primary with oligometastatic prostate cancer. I think it is a reasonable standard of care, but it would also be reasonable to leave the primary alone until we have further data, or perhaps longer follow-up, from the STAMPEDE study. In the United States, I think at Johns Hopkins, for example, we do offer primary radiotherapy to men that have less than 4 metastases, no visceral metastases, and about half of those patients end up getting it, either because they agree or the radiation oncologist agrees, but not every patient gets it.
Sabino, now we have this new scenario, the non-metastatic castration-resistant prostate cancer, and we already have had the Spartan and Prosper trial, and now we have the Aramis trial. So we have 3 drugs to select for this, I would say, perhaps a small subset of patients or a small scenario. Because actually, in my practice, I'm not sure if you all agree, but I even would like to know your opinion about that. But I think it's just a small percentage of a patient population. I haven't seen, like recently, a patient that is truly non-metastatic CRPC, at least nowadays. But in this case, what would be your option, or how would you guide your treatment for those patients?
Excuse me, but mainly if you use like PET-PSMA to stratify these patients, right?
Yes, actually, we have now 3 options that we doesn't have it on the past. Aramis is the phase 3 trial. The setting of the patient is the same of Prosper and Spartan. The patients had to have PSA doubling time less than 10 months, or total PSA higher than 10. And we had a positive surrogate that survival free metastasis is positive for darolutamide, as well apalutamide and enzalutamide. So we have 3 options now to, how you said, little patients. And here in Brazil, we had the PET PSMA that we usually do it when we have this situation. We have a patient like M0 CRPC, and we usually do the PET PSMA, and maybe can identify metastasis, and now this patient is not more M0 and then M1. So it's difficult. Darolutamide is not available in Brazil yet. So here in Brazil we have apalutamide and enzalutamide, and I'm comfortable to use both of them.
Fabio,
And I have
may I have a question
yes,
for
of course.
all of you? So in those trials, staging exams were either MRI,
Bone scan?
bone scan
yeah,
and
it's
MRI.
Normal imaging.
So if we do a PET with PSMA and we identify like 2 small bone mets, and the bone scan was negative and the MRI was negative, should we treat them as M0 or as M1? Because in the
It
trials,
doesn't in my opinion, it doesn't matter.
Yes.
You're going to use the data as you wish. If you go retrospective to the Spartan trial, I think there is a data showing that 100 patients that were eventually did a PET CT PSMA, I think 90-something% had metastasis on PET CT PSMA. So I don't think it's just the drugs work. It doesn't matter if you have or not metastasis.
Okay.
But I just have one tricky question for you, Emmanuel. We were always thought that you shouldn't pay attention to PSA progression using, for example, abiraterone. And now, out of nothing, we have to pay attention for the PSA progression for the non-metastatic CRPC. Why is that?
Well, in non-metastatic CRPC, not just the absolute PSA, but the PSA doubling time is the strongest prognostic factor for metastasis-free survival and also for overall survival. So although in the past we were not paying attention to PSA on its own, the doubling time, which is a kinetic, the rate of increase, is very strongly prognostic. So if the PSA doubling time in non-metastatic CRPC is less than 10 months, the median metastasis-free survival without any additional therapy is about 2 years. And if you're a patient and your PSA is rising and you're taking Lupron, for example, and your PSA doubling time is less than 10 months, you know that within 2 years on average you will get a radiographic metastasis with conventional imaging. Probably with PSMA imaging you already have a metastasis there, but you will find it with conventional imaging. And because all 3 of the studies that you mentioned, the apalutamide study, the darolutamide study, and the enzalutamide study, all required PSA doubling time less than 10 months as an entry criteria, I think we are obliged, at least I think it's the responsible thing to do, to preferentially select those patients for treatment with the 3 drugs. Of course, darolutamide is not available in the United States either yet. It's not FDA approved. But this also brings up the point that about 50% of patients with non-metastatic CRPC have a very slow PSA doubling time, more than 12 months, sometimes more than 24 months. And because these drugs are not free of side effects, the last thing that we want to do is use them on every patient with non-metastatic CRPC, because we may be harming those patients whose PSA doubling time is so slow that they may never die of their prostate cancer. So we have to be very careful. We should use the drugs when the disease is aggressive, PSA doubling time less than 10 months. And in those patients, we have an unequivocal metastasis-free survival benefit. And maybe we will see an overall survival benefit with at least one of the 3 drugs. We don't know yet. But I am fairly convinced by my own experience that patients that have a slow PSA doubling time, they may have more problems from the side effects of these drugs, and we may not be helping them.
Okay. Okay. So I think that's it. I would like to thank everyone for being with us.